Welcome to the Cup of Nurses podcast.
What's up, guys? Welcome to the Cup of Nurses podcast with your hosts, Matt Slarchik and Peter Findero. This is a podcast where we tackle hot nursing topics and current health news one conversation at a time. Welcome, guys. Thank you for subscribing. Thank you for listening. We love you all. Peter loves you guys sincerely. We are hanging back today, and we are sipping on some Jack, right?
Yeah, I'm straight cereal today.
You're straight cereal?
Straight cereal.
We're having a good time. I think we're going to have some laughies today.
Yeah, let's do it, man. Well, while we take a quick drink here, guys, check us out on YouTube, download our episodes, join the Facebook group, all fun stuff.
Yeah, so we're going to be a lot more interactive on Facebook. We'll have conversation, ask you guys things, and be very interactive. So make sure you guys find us there.
Yep.
What's today's topic, Pete?
On today's episode, we're going to talk about this large study that's been done over a decade on sugar, and we're also going to talk about intubations, emergent intubations, the process, common meds we use, the equipment, and just some more bedside stories.
The bedside stories. The scary ones where we think that shit's really hitting the fan.
Man, shit always hits the fan at one point or another.
I know. So this study, it's a giant cohort study. It's from Europe, and it had over 450,000 people. So this is a study from the European Perspective Investigation into Cancer and Nutrition. It's a large study over 10 different countries in Europe, and it spanned from 1992 to 2000, right? This is where the group came from, the patients.
Huge. Yeah, 500,000 people, that's insane. Like, usually when people do studies, it's usually, especially with people, it's usually like hundreds, maybe thousands, but this is 500,000 people.
Yeah, and we usually say like, oh, this is 1,000 people. You know what? I think this is really correlated to this, but this is 500,000 people with these results.
Right, and it's done over a decade too. Like, this is a decade's worth of research. That's a lot of number crunching over there. It's pretty good stuff.
And this was investigating sugary drinks, whether they have an effect on our health. And what do you think the results are with this?
Well, probably, I'm sure we could guess the results. Mm-hmm. But so this study actually separated sugar-based drinks and artificial sweetened drinks. So that's like your, no sugar, 0 calorie drinks. And a study, well, let me talk about the population first. So 70% of these 400,000 people were majority women. 70% were women.
Okay.
Average age was 50, and then they did the follow-up tests or follow-up with the patients or with the study, the follow-up with the population.
Yeah.
Was 16 years, 16.4 years, which is a really good length of time. That's a pretty long study. And as we all could have guessed, the results were negative. Sugar is bad for you. So the results showed actually the sugary drinks, if you consume 2 or more glasses of a sweetened beverage, you're more inclined to dying through digestive diseases. And if you drink 2 or more assorted artificial sweetened drinks, you're more prone to getting circulatory diseases.
And that's like
heart
your
disease.
That's like your diet soda, diet Pepsi,
Exactly.
things like that.
Yeah. And they initially had this study done in 1992 and then re-examined the people in 2000. So out of these 500,000 people, 4,693 of them died within a 6-year time frame. And those people were the ones that were drinking 2+ glasses of sugary beverages or the non-sugary beverages, the artificial sweetened ones.
And just because you think you're drinking a drink or a Pepsi a day doesn't mean you could run away from these results, because you're just as more likely. And who knows, you might be having extra like sanitary lifestyle habits that are being more prone to it, like smoking, right?
Yeah, and actually, this is actually a really good study too, because even so, they grouped these people into non-smokers and smokers, and also people that were overweight that had a higher BMI and people that were lean. And the negative,
was there a difference?
So the negative results carried over to each group. So it doesn't matter if you smoke or you didn't smoke, you still had this higher incidence of circulatory and digestive diseases, which is actually pretty remarkable. So that shows that sugar is a key culprit in early death.
Early death, yeah. And I feel like a lot of people always have this like stigma of like, I'm skinny, I could have a pop, I'm not fat. It doesn't matter if you're skinny or fat. You just have great genes that are burning fat, but yet you might be sick.
Yeah, exactly. Or they switch from, the sugary drink to the non-calorie artificial sweeteners, and it might not be contributing as much to circulatory disease, but you're now more predominantly going to get sick from digestive disorders. You're more prone to GI bleeds, and intestinal health, not gluten sensitivity, but this like sensitivity in your GI tract. You change your gut flora completely, and that just leads to a bunch of diseases. Like we mentioned a few times on a few episodes about the Parkinson's disease and how it's linked to GI health, and people die from that kind of stuff, and it's unfortunate.
Yeah, and also I noticed that it makes me more hungry, so leads me to eating more because like if I eat something very sweet before I start my like 16-hour fast, I'm like it's like 10 hours and 8 hours and I'm kind of really fiending some food. Like it's like my energy levels aren't up there after having a very high sugary, high carb meal
Exactly.
before
Yeah.
I start.
Yeah, and I'm sure a lot of people can relate. It's like your insulin spikes, and then you feel full, you feel good for a little bit, and then you drop back down to baseline, and you feel like shit. And you're like, damn, where's the next sugar at?
Yeah. And this next topic, so we're going to talk about how sugary drinks affect your body. Every single system gets affected in a different way, which leads to like negative side effects. And we can start with the top, right? The brain. So the brain is a system where it creates memories. There's a lot of neurons and all this stuff going on. And we're not realizing that sugar is literally hijacking our good chemicals. We're releasing large amounts of dopamine, which explains why we kind of crave sugar throughout our day. And there's so much studies that are like linking like little mice, right? Or is it lab rats, whatever you want to call them?
Yeah.
Lab rats, that's fine for today. So these lab rats are literally choosing like sugar. Like there was a test that tested the Oreo filling compared to like cocaine, and these rats were more hooked on the Oreo filling and consumed it and chose it over than cocaine. And it just shows you how sugar hijacks our brain because it's mostly made out of sugar, and it's just leading to bad negative feedback loops in the brain.
Right. It just releases so much dopamine at a certain time, and it's so easy accessible, or it's even more dangerous than certain drugs in the dietary aspect. Like, I mean, obviously sugar is not as dangerous as like heroin and crack and cocaine, those kind of drugs, but it's just so easily accessible where it can be just as dangerous. Because you could go anywhere and buy it, and it just releases so much dopamine, and if you really wanted to, you could keep eating sugary foods and drinks, and you could always be on a dopamine rush all the time. And then you crash real hard when you stop eating it. So what do you go back? You feel like shit, so you keep eating more.
When I see these people like snack on like a 50 calorie sugar Pepsi, then they got a Twix, then they chase it up with some chips, it's like, damn, dude, it's all sugar.
Right. Exactly. Absolutely no nutrition value at all.
And a lot of people don't realize it, man, and it's unfortunate. But that's why you guys have us here, right?
Right. Like, especially like with sodas too. They're acidic. That's probably why it's more attributed to GI disorders because acidity. I just thought about that right now. Or GERD happens. Just because you're just swallowing basic acid. And
I
has
wonder
no
if it's
benefit.
linked to like peptic ulcers and things like that.
Yeah, digestive disorder. So peptic
it?
ulcer, GI bleeds. Yeah, everything has to do with your GI tract issues. Diverticulitis. It's all contributed to by sugar and soda.
And if we go down the list, we now have the teeth, right? And we kind of hear the stories all the time that your mom tells you, hey, don't eat sweets late at night. It's bad for your teeth. And it really is because when sugar is on your teeth, it doesn't matter if you brush them regularly. This bacteria acts so quick and it starts eating the sugar on the teeth, which is like breaking down the enamel, I believe.
Yeah.
And it's just causing more cavities, guys.
Yeah, it's just like quick and easy access to glucose. Your bacteria is there. They want to eat. They want to thrive, and their main source is sugar, and it's just so easy to ingest and break down for the bacteria. Where it's just such a simple sugar where bacteria just digest it and they spread like crazy, like those lab rats. Goddamn lab rats.
The next one is the skin, and as we know, sugar affects like this whole metabolic cascade and causes that syndrome that we talked about before in our podcast episode, and it causes like the skin to age faster. There's something called AGEE, which is called advanced glycation end products, and literally these molecules age your skin. What exactly it does, it's been shown to damage collagen and elastin in your skin, and these protein fibers that literally keep your skin nice and firm and youthful, guys. It's like the people that drink the alcohol, the people that smoke the cigarettes, and they look like they're aging faster and looks bad on you. Like sugar has the same effects.
Yeah, it's crazy. And then it's also, what's the next one? The liver. It's basically sugar toxicity. Your liver can be processed so much, and with all the insulin getting released, your liver gets damaged, and it's not able to process all of it like alcohol. We get drunk because our liver doesn't process all the alcohol at once, and that's what the effects of drinking is.
Or you hear that kids are obese, like they're like 15, they have a fatty liver disease. Like, guys, how are they getting a fatty liver disease? That's usually related to alcoholics, but now it's related to freaking sugar, man, and diet.
Yeah, liver's your filter. It's obviously going to filter that sugar through everything that comes into it, and it's just, there's so much sugar there where it just gets backed up. and it just gets backed up, and then you get liver damage, like you said, fatty liver,
Yeah.
cirrhosis. It's all linked together, and it's very, very sad that something like this, like sugar, that's been around for years and years. Back then, it was used as probably like as a luxury, like back in the Roman era or 1900s, where sugar wasn't as accessible, so people didn't consume as much. So the effects weren't as bad compared to now, where you go to Walmart, you go to a store, and the main ingredient is sugar.
Yeah. When I was in Poland, because we didn't have candy as often. Like my grandma, I used to come up to my grandma's house. She used to give me a sugar cube, like even through the window. Like she was just chilling on a wheelchair. She just gave me a sugar cube.
Yeah.
And it's funny how that was like a little treat for us, and that was like good enough for us. And now it's just accessible.
Right. Yeah. I stayed with my parents when they were in Poland. Like they had rations because there was still communism going on, and you had a ration. You need to ration food, and chocolate was really expensive because no one could really get.
What are
expensive.
rations for people that don't know?
So rations
like
is
slips, right?
Yeah, slips, and it tells you can only get 1 pound of ham and like a loaf of bread, because it was communism. So it was another branch of socialism, you could say, but very more extensive, and you could only get whatever the government allows you to get. And chocolate was very hard to get because that's like a luxury. You don't really need chocolate to survive. You eat it more for like the dopamine rush, just to feel good. So they ate meat, bread, cheese, and all that, and chocolate was a luxury. They would take one chocolate bar, and there was 4 of them, and they would just break it over to 4 people.
Damn.
They had like maybe once a week. And it's not like now where you get chocolate everywhere you go. And it's leading to all these unfortunate diseases and illnesses.
The next one is the heart, and sugar. Literally, whatever we don't use up as energy turns into like triglycerides, right, and extra energy sources. And all this extra excess sugar that's circulating in your bloodstream is literally causing like atherosclerosis. It's affecting our circulatory system. It's making our veins and arteries literally stiff and tense, less elastic, and it's leading heart strain, right?
Yep.
It's causing our heart to work harder and causes damage over time in the long run. It's not gonna happen in your youth, but you're more prone, just like they said, to heart attacks, strokes, and all the other issues because of the diet.
Yeah, sugar, too much sugar, excess sugar causes literally inflammation in your arteries and your veins, which, like Matt said, causes stenosis, and you're eventually your heart ends up growing. Atherosclerosis, and eventually your heart hypertrophies, and people get into CHF, heart failure, just because of sugar. Sometimes we don't know why diabetics go into heart failure or CHF. They don't really have any kind of history of it, and you realize that they have unmanaged diabetes and their sugars are out of control. Everyone sees up, and then that literally causes heart disease. Mm-hmm. It's very sad. Like you said, at a young age, like it started at a young age, and people just don't change, don't stop, and these things you can't always feel them. You don't feel your heart getting bigger. You feel your heart getting bigger when it's to a certain point where you become short of breath and you literally can't breathe.
You got to come in.
Yeah, and it's sad.
Like the kidneys too, man. Like it's an awesome organism that filters all this stuff, and we don't know like these little cells that are filtering this urine. It gets damaged, and over time, like the diabetes are literally destroying our kidney cells, our kidneys as general, and then the kidney doesn't function as an organ properly, and your creatinine builds up, your uric acid levels build up, and you got to get dialysis, man. And these people, a lot of these dialysis patients, if you guys think about things or ask, if you're in the medical field, just look at the correlation between like end stage kidney failure, people on dialysis, and if they have diabetes. More than likely they do. Like, and that's like one of those things that when it goes bad, it sucks, man, because dialysis is like 4 or 5 times a week. Like it's a commitment, man.
Yeah, it's ridiculous. Like we said, it affects your veins and your arteries, but people may think those are small vessels, but they're really not. There's even smaller vessels called capillaries, and those are the first ones to go. And these organs, livers, your lungs, your kidneys, they're very capillary dense. So they're even smaller than veins, and they're the ones that get clogged up quicker, and those are the ones that get damaged the most. And once those are damaged, they're so small, they don't get repaired.
Right.
And your body can make more capillaries, but it's hard to make capillaries when you have high blood sugar because your blood does become a little more thicker. I think, is it viscous the word?
Yes.
Yeah. And it's just hard to make those capillaries because they just get clogged back up right away. And then that leads to poor perfusion, and you can't perfuse your organs as much, and you get kidney disease, you get fatty liver, cirrhosis of the liver, and because of sugar.
Yeah, and we know body weight is obviously, and there's nothing to touch about it. It's linked to type 2 diabetes, it's linked to weight gain, and there's also sexual health. And they're linking high sugar content, and it has an impact with the erection. Is that what I'm reading?
Yeah, it's exactly. So I'm not forgot what the exact term was, but impotent.
Impotency.
Impotence
Okay.
is unable to get erection. So, you know, your girlfriend's having a good time, you know, and you go to bed, you can't get it up.
Or you
maybe
had that cookie before, man. Now she's asking for the
Mm.
D, and you just can't give it.
you can't get it up, and you can't figure it out. Your testosterone's fine, all your hormones are fine, but you're just maybe consuming too much sugar.
Yeah.
and can't get the
And then
benefit up.
add on to it, then you have anxiety about that issue, and it just makes it a lot worse, guys.
Whole giant cascade, man. Unfortunately,
Stay away from your sugar, guys.
yeah.
Let's do an intro to intubation. For those people that are non-nurses or students, like, have you ever wondered about like the process about like intubating somebody, which is aka putting them on life support and putting them on a mechanical ventilation? And we're gonna discuss that process, the equipment, and their little bedside tales here, right?
Yeah. So no matter what kind of nurse you are, no matter if you're med surg, telemetry, there's gonna be at one point or another where you're gonna call rapid or a cold where you're gonna need to intubate somebody.
Yeah.
It's not crazy common, but you are gonna see because you're a nurse over an extensive period of time, over years, and eventually you are gonna get hit with the need for you to help with the intubation. If you're not the main nurse, you're gonna be doing something, you're gonna be giving supplies. So it's good to know, and it's always good to know ahead of time before it's too late. Then you're kind of stuck and don't know what to do when you're asking for help when everyone's busy.
Yeah, and that's how I started too with intubations. Like, I used to always like observe them and just figure out what the heck is going on. Because at first, the whole team is working as one man. It's like this system of like, what the heck is going on? But once you get into a flow, you're an awesome, effective team member, and you just know what the hell has to happen. You look at the room, this, boom, boom.
Right, just like with a lot of nursing skills, intubation is a thing where the more you do it, the more you learn and the better you get at it. It's just one of those things that you don't see outside the hospital. It's not like playing basketball where you could play at any kind of basketball court. This just happens in the hospital. So, the more time you deal with it, the better you are going to get at it.
Yeah.
Don't be afraid just because your first time was bad or you were too slow. You can get better at it. Just, unfortunately, it's how it works.
Yeah. So the reasons for intubation, did we discuss this?
No, not yet.
Okay, so it would be an obstruction, facial trauma. The patient becomes unconscious. You have profound hypoxemia, usually diagnosed with like an arterial blood gas, respiratory failure. Let's just say you're in cardiogenic shock. You're on BiPAP, again, hypoxemia, and you have to be intubated. Also, after surgery, sometimes you get intubated for procedures, and they have a hard time extubating, so they might come to you already intubated, and you're going to do the weaning process.
Right. Not all intubations are emergent.
Right.
When you go get your tonsils pulled out or you go for, a stent placement, those are elective intubations. Those are done in the OR or right before the OR. Those are kind of more calm because that's when those nurses are trained for that situation. They've been, intubating people for their whole career. So that's a little bit less hectic. But your bedside intubations, those are usually the ones that are emergent. Even though you are going to have those times where, someone's getting intubated, but it's still an emergent one.
Yeah.
Because you still gotta hustle your ass.
So the
to get
process.
stuff. Exactly, just the process. And then you have those patients that, like Matt said, are on BiPAP. It's just not working out. You're doing their blood gases, and they're just keeping acidotic. Even though they're completely with it, their numbers look like shit. Those are kind of elective emergent, you could say, because you're gonna tell the patient, be like, hey, we're gonna need to intubate you, so this is how it's gonna be, but still emergent because you are called anesthesia.
And the family and everything that happens, and looks very terrifying for them. And the kit, that's the go-to kit, is a rapid sequence intubation, guys. So sometimes it's a different color. Ours is a nice little case, looks like a pencil case with red top, and it has like a little clip for, patency, whatever. And it has your awesome meds that you need in order to intubate.
Yeah, ours is like big, like one of those like construction boxes where you keep the tools at.
Okay, we have that too for like the different ET tube sizes.
Yeah,
and things.
same. Yeah, we just have everything in that box, and then we just bring that box. But for us, usually anesthesia brings their own stuff. Okay. So it's really convenient.
So what do you think are like the clinical signs of like an intubation?
Well, like we said before, the blood gas is sort of acidotic, so pH is less than 7.35, and it's not improving. Bicarb is compensating, so it's high. And your CO2 is high as well.
Yeah, like the CO2 above like 60, and like you can tell they're very fatigued, or sometimes it could be drug overdoses, man. Sometimes we cause it, like giving too much Ativan, or too much morphine, man. I mean, sometimes you could use a reversal agent on that, but having those ETOH patients that are just being too much to handle, like you'll intubate, man, to just protect themselves.
Right. So sometimes it's based on numbers, like we mentioned. And sometimes it's just to protect their airway. Like the patient isn't swallowing properly, or they're at risk for aspiration, or they just can't keep their airway open. Like they extubated somebody, but their airway is so inflamed that they just got reintubate. And so there's certain diseases like, what's it called? I'm not sure what it's called, but where your tonsils swell up and you need emergent intubation.
I don't know that word.
I forgot what it's, hyper or something. I don't know. But it's where tonsils swell up and you need, a lot of kids have it.
Okay.
Where they need emergent intubation at the hospital because it just closes up and then they deal with it with antibiotics. But yeah, so a lot of times it's numbers based. And like you said, the person might feel fine, might be fine, but their numbers are just crummy. So we're just like, the best thing for us to do is just intubate you and we'll breathe for you.
Yeah.
Just to get those numbers better.
And the equipment that you need at the bedside, so one of them is you need an ECG. So either if you're in the ICU, they're already hooked up to the monitor where you're evaluating their heart rate, or you have the crash card next door you put on the lead, so you have that available, right?
Right, you need consistent monitoring, cardiac monitoring.
Yeah, that's one. You need an oxygen saturation. You have to find that out. Another device you need an end tidal CO2. Like you have to find out what the end tidal CO2 is after you intubated to make sure you're actually in the lungs perfusing properly, right? Sometimes if the end tidal is not above, is it 30?
35 to 45 is the normal end tidal CO2.
Yeah, that's okay, yeah. So anything above 30, you're like, okay, we're in the lungs. Yeah. If you have a bad number, there's probably something's up. And A-line, that's like an iffy one. I know you talked about it. They do inlines for you.
Yeah, usually when we intubate somebody, we just, film an A-line because I do work on a cardiac floor. So usually if we're intubating, their cardiac issues, their cardiac health is probably going to shit as well with their breathing. So we usually like to throw an A-line in them. But a lot of times in ICU here, we already have A-lines in them.
Okay.
So that's convenient. Or we throw a central line in them because you can't really give certain drugs peripherally for a continual amount of time, like your pressors and stuff. So we either give them a central line bedside or like an A-line.
Yeah.
Something like that.
A-line doesn't happen too often for us.
But they should definitely have some kind of a peripheral, at least some peripheral access.
Oh, you need one. You need one. That's 100, guys. You need at least like a 22 gauge in there because you're going to be pushing heavy duty medications prior to the intubation. Right. So you need something for the intubation process. And you also need a bag mask. So you got to bag them prior to the procedure usually. Sometimes the intensivist or whoever is intubating is having a difficult time and they might give the patient a break because they're desatting too low. And you're going to bag them for a little bit, bring their sats back up to 100%, whatever the case might be, and then try again,
Yeah. Right, and then usually they bring their own laryngoscope. I know you guys call it
I call it a kaleidoscope.
Okay.
So
same thing, just so for...
Or they call it a Mac blade.
Mac blade, yeah, just something so the resident or the anesthesiologist can see where they're going down into the throat because, they have their own markings that they know in the airway that they go by. I'm not sure what they are. I know someone would do with the Adam's apple and stuff like that, but they have their own markings that they pay attention to when they go down and actually intubate somebody.
And we have with the blades, we have a little camera hooked up to it, so they're kind of looking on the side to visual the vocal cords before they stick the tube.
Yeah, and then the ET tube itself, probably a few different sizes because you're not sure how constricted the airway is.
Yeah, I see a lot of 7.5 ET tubes, but I work in a older population.
Yeah, 7.5s are basically what I see almost all the time too.
And let's not forget about the suction. So sometimes you have to have those difficult airways where you're suctioning. There's a lot of secretions. You can't visualize what's going on. Sometimes there's blood. And worst of all, if there's vomit, if the patient's aspirating, that's the worst because you see all this stuff in the cords, man.
And they're at risk for aspiration like 80% of the time.
Those people are going to be on the vent for a while on antibiotics because they're going to get pneumonia. Yeah,
and someone to secure the ET tube as well because there's been times where the respiratory therapist they have their own clip that they use to secure the ET tube in place. But sometimes the thing cracks because everyone's kind of frazzled. So at least have some tape on you. At least tape it to their cheek or just tape it somewhere so it stays. Mm-hmm. And then probably like an NG tube just so you could put that down there
afterwards. Yeah.
And
at that point, it's called an OG tube because it's going through the mouth, guys. Yeah. Good point, indeed. Let's talk about the process.
Like we said, guys, we're cereal today.
We are cereal. Cheers to that. Let's have another drink in between this.
We should have a drink every time we say a full sentence.
Well, we wouldn't make it.
It's about to be cereal with milk pretty soon with this, man.
We're also thinking about a podcast episode to talk about the side effects of alcohol and just kill a quick 6-pack on the show. that's to be determined when that's
Or some more of
happening.
these.
Or some Jack.
You know, a lot of carbs in a 6-pack of beer.
Yeah.
I'm not sure how much carbs Jack has. We'll tell you for the alcohol episode. We'll break it down for you guys.
Exactly. All right. So the process. Usually there's going to be like a diagnosis, or somebody's going to be like, okay, we're intubating. And if it's if you're calling a rapid response, then you already know what's going on. The patient's already in respiratory failure. And we're not going to talk about the intubations when the patient just rolls in, because that's regular.
Yeah.
So let's talk about just emergent. Usually the intensivist says something's going on. You would see some signs that's saying, hey, we need to intubate and we need to prepare. Depends on what's going on. Usually I like to prepare the room for whoever's intubating, right?
Yeah.
So I'll undo the brakes and I'll push the bed back a little bit, get that set up, and then usually the nurses know what's going on. They could help.
Right.
But if not, we got to gather all the equipment, which we talked about.
Yeah, so if the patient is conscious, you should definitely explain what is going on first, just so you lay them flat and then bang, they got a tube down their mouth. You want to explain, hey George, we're gonna intubate. You're not doing too good. If they can sign a consent, have them sign a consent, or at least explain what's gonna happen. Be like, hey George,
It's emergent, so more than likely
true
it's
True that. So what you said, move the bed up a little bit so there's some walking room. Remove that headboard, lift the bed up a little bit, like a little bit above the hips, and just so everyone's at a comfortable. There's some short residents or short anesthetists, so they just make them comfortable.
Yeah.
But make the patient comfortable too. Be like, hey, we're gonna give you some medication. You're gonna feel drowsy. You're gonna fall asleep. You might wake up with a tube down your mouth. It might be uncomfortable. Trying to bite down, or you might not even remember us doing this.
Yeah.
But it's gonna be uncomfortable.
Yeah. So you definitely need a respiratory therapist, someone that's in charge of the airway. You're gonna have your intensivist / resident or whoever doctor that's gonna be doing the procedure. I know a girl in Canada. Shout out to you, whoever told me this in Canada. Respiratory therapist intubate. That's awesome. I would definitely love to have one on the show to talk about that. And after that, you need a nurse that probably just is getting supplies, right? And usually a lot of people like to stand by and watch because like, what the heck's going on? And the last person is the person that pushes the meds. Right. And I like to do that a lot. And that's where the rapid sequence intubation kit comes in place. You like to draw up all your meds. Usually I'll ask the doctor before the procedure, hey, what do you like? We're going to talk about the meds, but usually some Versed or fentanyl. I'll draw that up into syringes. So don't forget, guys, you need some saline flushes because you have to push the meds, and you need some empty syringes with some 18-gauge needles, not to waste your time and just pull back right away. And what I like to do is, because you sometimes have 3-4 different kind of meds, usually 3 in the kit, I like to, let's just say, draw back on the medication and then tape the medication to the syringe, just so I know what I'm pushing. Because sometimes with all that's going on, you don't know what you're going to push, and sometimes you could push the wrong med.
Yeah, what I like to do with that meds is sometimes I tape them, sometimes I don't. I have them in alphabetical order, so from left to right. So if I have fentanyl Versed, I would do fentanyl on the left and a Versed on the right in my hand. And what I also like to have is I also have myself and 2 other nurses. So like Matt said, one is ideal for supplies, but usually they're crowding around you, so there's always a handful of nurses standing out there. But like Matt said, one for the supplies at least, and then one for the meds, and then me as a nurse, since Matt likes pushing meds, I prefer to just look at the vitals. Like, hey, he's sitting down. Let's try this again. Let's extubate him real quick, or move that tube out of there, and I'll give him some few pumps of the bag. Or you just say, hey, he's getting tachy, or he's now an SVT. Let's try and work it, because as an anesthesia person or the resident, their main focus is just the airway. They're just trying to get the YouTube, but they're not looking at the vitals. They're not looking at the pressure. Someone has to look at that stuff. Yeah. Because they can't be looking at everything, because that's too much work for one person.
Yeah. I think they've been pushing for during the rapid response, there's 1 leader. So 1 leader is in charge of the situation, and he's making aware of what should be done. Yeah. Usually sometimes like to wear the tags, and she's the one that's going to be like, okay, guys, hey, he's satting like 60%. Let's bag him a little bit just to kind of let the resident, or say, hey, 40% sats, just so that doctor can make the call, not you.
True.
Same thing if you're pushing the meds, right? You want to be very verbal. Hey, doc, I'm pushing 5 of Versed now. Okay. And he, just so everybody knows what's going on, and not like, oh, I thought you did this. No, I didn't do it. Like, everything is verbal. Communication is just flaw.
Yeah, it's got to be straight verbal. Like, you can't assume anything is done. Just like a code, like, you can't assume it's been 2 minutes. Someone has to say, hey, it's been 2 minutes, pulse check.
Yeah. And
you can't assume the med's been given or what med's been given. Someone's actually got to say, hey, pushing Versed, pushing Fent. Because there's no way of telling, and everyone's focused on one specific job, and that's how it's efficient, is everyone's yelling out what they're doing, but not all at the same time, obviously. And everyone's just focused on their thing. One person looking at vitals, Matt's pushing meds, then anesthesiologist intubating, and then, the third nurse is getting a smaller
and you have those like intubations or rapids that are very, very like unorganized, and you can tell when it's an unexperienced nurse, or maybe you're on the floor and you can tell there's not enough communication, or just someone's not doing this, or you intubated and where's the end title, like what's going on, like, and it happens, guys, and that's how you get better as a team or people on your unit, just through these experiences.
Exactly. Yeah, and once they're intubated, maybe they want to throw an A-line in, so you should grab your A-line stuff, have somebody grab it for you, or your central line stuff. And then you also want to make sure that the cuff is inflated. Because I've had a few times where the cuff wasn't fully inflated and the ET tube ended up being like dislodged, or not dislodged for me, but I've seen it being dislodged for somebody else. But it's got repositioned, and then, the patient's desatting, you're like, damn, I got to call anesthesia again. And sometimes the cuffs, even though they're not supposed to, they're supposed to work properly, some of them are actually, like popped. Like you try and inflate it and you can't inflate it. So then you got and then you got to extubate and then re-intubate them again.
Yeah, that's my little bedside story about that. And let's not forget, after the ET tube goes in and all the drama happens, we always want to check breath sounds bilaterally. I'll do that always, even though like doctors do it, or sometimes ask me. And then always, which is the gold staple, is that chest x-ray. Yep. You want to confirm placement, make sure it's above the carina, right? You don't want it to be in the right stem or something and not ventilating properly.
Right, yeah, and then get your drip set up. Because
that's another one.
You pushed, but there's half on these drugs. They're gonna start waking up eventually. Doesn't matter if you give 100 of Fent, for a big guy, he's gonna wake up eventually. So
yeah, they're gonna start bucking the vent. You're gonna hear a bunch of alarms going off. He's gonna start waking up, try pulling and going crazy, and you want to put those little floaties. Some people in their ICU, they restrain, just so you're protecting the airway and you're protecting him from extubating himself.
Yeah, usually I just throw them on restraints. Once they're intubated, I just throw them on restraints because you're never really sure how someone's going to react when they start waking up. You might think they're snowed 1 minute and you leave to get something real quick. You come back and they're moving around, they're upside down in the bed. You're like, shit, I should put them on restraints. So you're about to put them on restraints right away and then discontinue them a little bit later on once they start opening their eyes, or they start following commands a little bit. RAS score starts to improve a little bit. Then you can take out the restraints, and then of course if they start thrashing or trying to pull their vent, put the restraints back on. That's what they're for.
And you can't trust your patient. Like they said, they're not going to pull the tube, and they're all sincere on the tube, and you took the floaties out because they'll yank it, man. I had a lady that did it too. She was like 29, young lady, man, just fucking yanked that shit out at 2 a.m.
Exactly, and then they got reintubated. Whole process starts over again. So now we'll get into the drugs. So you obviously need your sedation. The most common sedation drugs you can use is Versed.
And this is in the RSI kit, guys.
Yes. Or, well, for us, we have it in the unit, but a lot of our residents and anesthesia like to bring their own meds.
Okay, cool.
Because they usually, sometimes they draw them up themselves, sometimes they just bring vials, just because they're not sure what kind of unit they're going into or how experienced the nurses are, so they just prefer to grab it just because it's a little bit more efficient for them. That's what they prefer. So like sedation, so it's going to be your Versed, your Fent, etomidate. Sometimes we use propofol, but the ones I see most is usually give Versed and Versed and fentanyl. That's usually the combo that we give, like either 5 of Versed and 50 of Fent, or 2 of Versed and 25 of Fent. That's probably the most common one.
Those are the big ones, and the physician will base it on what's going on. If they're hypotensive, they're probably not going to want to do too much Versed or fentanyl because that's going to affect them. And they're going to go the paralytic route and do like sucks.
Yeah, exactly. Yeah, so your paralytics, like Matt said, sucks. So, but you got to be careful. Paralytics, the person is paralyzed. So you kind of do want to sedate them a little bit because, they can't move. So imagine if you didn't sedate somebody and they're paralyzed.
Right.
But you're completely with it. That's probably the scariest shit in the world.
Yep.
It's probably so scary. I mean, I probably would freak out. I'll probably be traumatized, man, if I'm paralyzed and not sedated at all. Give them a little bit of sedation. Yeah, they might be hypotensive, but give them like at least a little bit of something.
Yeah.
Another paralytics that I guess people use there's like a rocorium, anything with an eum.
That's more in the OR type of thing.
Yeah, so those drugs, you need high doses and they don't act as quick compared to a Sux. Sux is probably the most common one that we use.
Dude, I remember this one time I had this guy, and he was an HIV patient too, which made things worse because he was in full-blown ARDS. And at one point I hear like going on in his ET tube, and I'm like, guys, I think his cuff blew. And like the intensivist was there, and she's just like, okay, we're gonna intubate out of nowhere. Like I just get my day started. I'm just getting my routine in check, and like, dude, we're intubating this guy, and I'm like, guys, you guys are gonna have to leave the room. There's a bunch of family. There's a rabbi, all this stuff, and we're preparing the room. And like, long story short, you guys hear the process of intubating. What was crazy about this is like, this guy was an ARDS, and he was desatting so quick. Like, we bagged him to 100%, and the intensivists, you know, what they do also that we don't talk about is if you're switching a ET tube one to another, they put a bougie in. So they put a metal wire.
Bad and bougie, huh?
Bad and bougie. They put a little metal kind of wire through here so they could take the other ET tube out and just thread it through instead of using the gyroscope.
Right, that makes sense, you know.
And she had such a hard time, and he desatted so quick in between that time. She had to take both of those things out, bag him again. Like, we're going back and forth with this intubation, man. Like, at one point, like, she was intubating, and like, he sat it all the way down to like 15%, and she was so like, this intensivist was so stubborn about intubating him that we're like, hey, doc, like 30%, 25%. She kept trying. I was like ready to fucking jump on this dude's chest. Like, I'm like, okay, we're gonna freaking do compressions because he's gonna flatline. Like, it was intense.
Yeah, it's a crazy ass story.
And like, the worst part is like you just go through like a storm of like events, and afterwards you get the patient nice and looking good, and the chest X-ray comes in, and the family comes in, and like, yeah, he's intubated.
Yeah, like nothing happened.
And yeah, nothing happened, but you just for 20 minutes you're sweating all over your body. You know, it's crazy.
Yeah, family comes in. Yeah, how was it? How did you do?
How was intubation?
It was good. You know, a little bit harder than always, but you know, we got it done. He tolerated it well. And your ass is sweating. You know, you got sweat dripping down your ass, and you just tried for like 20 minutes trying to intubate this person. Like you said, he's had a 15%. That's insane. You know, that's like almost cardiac arrest right there. You know, that's how it sometimes is. I don't have any crazy stories to share because, for the most part, my intubation have been smooth. But I don't know if that's fortunate or unfortunate, or I'm sure I'm gonna have one intubation. It's gonna come sooner or later where it's gonna be a fuck fest. But you know, sorry for my language, but dude, you know how it is.
Now we're not gonna be able to run YouTube because it's explicit content, man.
Sorry,
good
guys.
job. No, but yeah, man. Like, when it comes to intubation, guys, like, it's definitely a different experience. If you're in med surg or you see it for the first time with the ICU, it's crazy, and it's also beautiful the way we work as a team and we like save a life. I think that's amazing.
Yeah, it's real cool. Like, the one tip I would give you if you're intubating somebody, if you're not exactly sure what's going on or this is your first intubation, like, the best thing you could do for everybody is just keep an eye on the vitals.
Yeah.
You know, have somebody else push the vets. Like, just keep an eye on the vitals. It's your patient. You know how his blood pressure's been all day. Look at the vitals. You know, shout out, you know, systolics are dropping to, you know, 90s. And just let them know. That's probably your easiest thing to do is just look at the monitor. Compared to just standing there and just being like, you know, a wasteful soul in the room.
That's true. You want to wrap this one up?
Yeah, let's wrap it up.
Nice little quick cheers at the end, guys.
Yeah,
This is where we have to finish this, Jack. I'm almost done. Peter's kind of dragging.
Well, I hope you guys enjoyed the episode about intubations.
Likewise, guys. Comment, subscribe. We touched about sugary drinks, how this 450,000 case study basically proves that soda is bad. Cut it out, drop it, go to the fridge, throw all that out. It's bad for you. Just drink some water like normal people.
Yeah, even those diet drinks. Don't use, hey, I'm switching over from regular soda to diet soda, and that's your healthy thing to do. Nah, it's all bullshit too.
It's just as bad, guys. And intubations, you heard about the process, the procedure, what happens, tips, and just like, don't become an intubated patient. And if you are a nursing student, get ready for one because it's going to be hell of an experience.
Exactly. Or go watch intubation. If someone on your floor is getting intubated, go watch. Go stand in the corner and watch it. Don't be afraid of it. If it's not your patient, go watch at least.
Yeah. We'll see you guys next week. Take care.
Take it easy, guys.